So at the academic cardiology department in Hull, we've been doing some research into diastolic heart failure for a number of years. So just a couple of things that we've looked into. We thought, well, maybe this normal-looking ventricle is not actually quite as normal as it seems to be. So we looked at the long axis function of the heart, the longitudinal function of the heart. How we can do it? We can look at the motion of the mitral annulus, which is between the atrium and the ventricle. So the motion of the mitral annulus reflects very well the longitudinal function of the heart, and we have a relatively new method of non-invasive cardiac imaging, tissue Doppler imaging, that helps us to assess the mitral annular motion. So yeah, I don't have time to explain how it works, but this is just a trace of the mitral annular velocity, and it has three typical waves: a systolic wave and two diastolic waves, early and late. And these are two images acquired in a younger normal subject and in an older normal subject. So the difference is all the velocities with age go down significantly, and also the pattern changes. So here early diastolic motion dominates, here we have late diastolic motion dominates, but all three waves, if you look at the absolute value, the velocities, all three velocities are significantly reduced. So that's another quick illustration. As M is the systolic, the velocity of the systolic wave, systolic mitral annular motion. And again, this slide illustrates a linear decline in this velocity with age, so starting from younger people into 80 and over. That's another illustration from one of our papers. Again, here we have patients with diastolic heart failure who are supposed to have a normal function of the heart, preserved function of the heart, and here is entirely normal people without signs and symptoms of heart failure. And again, we can see that all three velocities of the mitral motion are reduced, so it's not entirely normal function these patients have. So how to explain it? Again, it's quite difficult to explain. We know that the fibers of the myocardium, they're not homogeneous, and those fibers are responsible for longitudinal contraction, lengthening and shortening, they are more endocardially located. So because of this subendocardial location, maybe they are more vulnerable to various things that happen in aging and in disease, such as ischemia, for example. We also found that patients who have impaired long axis function of the heart, they also have worse survival compared to patients with preserved long axis function. What we're doing now, we have a new piece of research looking at potentially important but unrecognized mechanisms that may work in diastolic heart failure. We feel that it may be isolated cardiac senile amyloidosis, particularly the forms of so-called isolated atrial amyloidosis, which may be unrecognized but important mechanism in diastolic heart failure. So there is some evidence confirming this hypothesis, but it's quite limited, and it's mainly coming from post-mortem and ante-mortem studies on patients undergoing cardiac surgery. So we are looking for more ante-mortem evidence acquired in our patients with diastolic heart failure, and we have a lot of them because there are more than 6,000 patients with heart failure under supervision, under treatment in our department. So we have a lot of patients, but we need to acquire this non-invasive ante-mortem evidence of that, and we're trying to do it using cardiac MRI with delayed gadolinium enhancement, which is a relatively novel method of cardiac imaging and showing promise in imaging cardiac amyloid. So luckily I don't need to tell you anything about amyloidosis. We've had a comprehensive presentation on that. I'll just say a few words about cardiac amyloidosis. So we have a few forms of cardiac amyloidosis. Most of these forms are rare, considered to be rare. Obviously, primary systemic amyloidosis, such as AL amyloidosis, for example, in patients in multiple myeloma, like the previous speaker said, it's a terrible disease. Most patients die very quickly. Luckily, it's relatively rare. Secondary amyloidosis, for example, in patients with infections such as tuberculosis, or in patients with inflammatory disease like rheumatoid arthritis. Again, it's very rare in the developed world. We have these cases of hereditary ATTR form of amyloidosis, also relatively rare. But here we come to senile cardiac amyloidosis, and this is the form of cardiac amyloidosis which we think is not rare at all. Actually, it may be very, very common, much more common than we think it is. And here we have two main types of senile cardiac amyloidosis. One of them is more systemic, with the involvement of both the ventricle and the HM, and it's related to transthyretin as the precursor. And the other one, which we believe is very common, is isolated atrial amyloidosis. And this is an interesting form of amyloidosis because the precursor of it is atrial natriuretic peptide, or ANF, which is released by the left atrium. It's always elevated in patients with heart failure. So it's very difficult. It's rather difficult to diagnose cardiac amyloidosis. So a lot of these patients are misdiagnosed. So we believe that there are a lot of older patients with signs and symptoms of cardiac disease who actually may have age-related amyloidosis as the substrate of their condition. But it's in many cases we believe it's misdiagnosed, undiagnosed, undiscovered. So it's not easy to diagnose cardiac amyloidosis because signs and symptoms are not specific. We have all these methods of non-invasive imaging, and probably except MRI, they don't give us convincing evidence of the presence of amyloidosis. So radionuclide imaging, it may help, but again there are some problems with the moving heart. Genetic testing may help for suspected hereditary amyloidosis. And also, this is the challenging part. We need, by definition, to diagnose amyloidosis, we need to obtain morphological evidence, so we need to get the biopsy material from somewhere. It's perhaps easier in systemic or primary amyloidosis because we can use fat aspiration, we can perform relatively easily kidney or rectal biopsy. The biopsy of the heart tissues is much more complicated. So, for example, it doesn't seem to be ethical to do it, for example, in patients with diastolic heart failure. And also, it's routinely performed on the right ventricle, so we acquire a piece of the right ventricle. But if amyloid is located in the left atrium, again, we can't get it. So it's very challenging.